So, okay, my disclosures, objectives. So we'll start with the first case. So this is case one. This is MH. This is an 82-year-old woman admitted to hospital with a hip fracture. She has a history of dementia and hypothyroidism, but no history of diabetes. Her BMI is 18. In terms of medications, she's taking Synthroid 75 mcg daily, donepezil 10, and Tylenol as needed. So she seemed drowsy, confused. So a random point of care glucose was done on her, which returned low at 1.7. There were no other documented symptoms. Of note, though, her hands were slightly blue or cold to touch. So she was treated with the hypoglycemic protocol. Her glucose went up to 8, but there was no significant change to her sensorum. So is this hypoglycemia? I'm going to ask this a couple of times throughout the presentation. It's meant to be reflective, so just for you to think for yourself as we go through this presentation. So is this case hypoglycemia? So she had repeat testing done, and many of them ended up being low. The team was asked to try comparing her hands. So she had a point of care done on her right one time, which was 2.1, and then at the same time on the left, which returned at 3.3. So there was some discrepancy. Then her medical team was asked to compare serum glucose to point of care. Her serum was 5.6 versus her point of care, which was 2.3, tested at around the same time. Endocrinology was involved and did general hypoglycemia investigations, and they were found to be normal. This included a serum glucose, A1C, an insulin, C-peptide, cortisol level, and a TSH. So a request was made to warm her hands prior to point of care testing. First time it was done, it returned at 5.3 millimole per liter, and then every subsequent test actually returned normal. So is this hypoglycemia? So what I'm trying to get at are possible causes of pseudohypoglycemia. And the list is actually fairly long. From a venous or serum calculation, it can happen with delayed centrifugation of blood. So you can actually have a 5 to 7% decline in the blood glucose for every hour of delay. And so that's why it's important when we do those morning draws, it goes from bedside to lab, from lab to be processed. Because if there is a significant delay, we're going to get inaccurate results. The other thing that you can get is differences with change in blood viscosity. So for instance, in the state of elevated white blood cells or elevated red blood cells, you can actually have a false low glucose reading. From the capillary side or the point of care glucose testing, there is also various causes that can result in low blood glucose. So this can include poor tissue perfusion. So for instance, shock or sepsis, and vasoconstriction. So Raynaud's cold hands, as was the case one, and meter inaccuracy. So from an outpatient setting, we usually like to have patients change their glucometer every 3 to 5 years. But even when you have your glucometer, you should do periodic calibration of it to make sure those results are still accurate. And of course, everything else is working in the mechanics. So the battery is charged, the strips are not expired, as all of those can lead to inaccuracies. Now, with the advent of technology and so many exciting things that are happening, a lot of individuals are testing interstitial fluid with the use of CGM or continuous glucose monitors. But unfortunately, these also have issues with low blood glucose levels. You can have false lows that can happen when you first apply a sensor, that can happen even up to the first 1 to 3 days. You can have compression lows. So when patients sleep on their sensor, they basically flatten or compress the interstitial fluid, can't accurately test, so it reads it as a low glucose. We find in altered protein states, so severe liver or renal dysfunction, there's issues with accuracy, as well as extremes of age, so the very young or the very old. And certain medications can actually impact this as well. So vitamin C impacts the Freestyle Libre, can cause either false highs or false lows. Aspirin in the Freestyle Libre can cause false lows. And Tylenol hydroxyurea can cause false highs with the Dexcom sensor. Still unclear the underlying mechanisms. There's potentially various. So either it impacts the assay that calculates the interstitial fluid, it affects the impact of drawing it from the interstitium itself, or it has a different change or cation effect on the interstitial fluid itself, which results in a false read. Now, the other category is normal, so within a realm of normal. So some individuals can have low-lying levels of classic low blood glucose, but still be perfectly normal. So this is an important slide just to know and make sure that you're not dealing with the realm of pseudohypoglycemia. So moving on to our second case, this is case of SB. And so this is a 56-year-old gentleman with chronic lymphocytic leukemia, had it for about 10 years. And over the course of the past 4 years, his hospital-based glucose levels have been a bit low, around 2.7 to 3.3 on quite a few occasions. Oftentimes, it was simply ignored and felt to just be due to the hyperviscosity of the white blood cells. So it wasn't really looked into until later. One time his doctor said, you know what, maybe we should just double check these glucose values, make sure we're not missing anything. In terms of the span of the day, he tended to have lower blood sugars in the afternoon. So his doctor ended up with a sample sensor and put it on and found that this patient was having low blood sugars 45% of the time. So this time testing the interstitium as opposed to the serum. So question is this hypoglycemia? So he was questioned further and he mentioned, you know, he did have some periodic sweats, but he really just chalked it up to his CLL. He may have noticed some occasional dizziness, again, felt it was related to his underlying condition. Fortunately, his wife was there and provided collateral history. She felt that he actually had slower thinking. There were times where he desired more sugar. If there was too far a time span between his meals, he actually felt more anxious before meals. And he did feel a resolution when he consumed glucose. So the question is this just an overcall? Are these chronic symptoms ignored by the patient, but noted by the family? Still a bit unclear. In terms of his past medical history, he had a history of CLL, CAD, dyslipidemia, hypertension, no history of diabetes, and no confounders with his medications. So is this hypoglycemia? So I guess we need to pause and actually define it a little bit more. What is the definition of hypoglycemia? Now, we're specifically going to talk about Whipple's triad. And the importance to know with Whipple's triad is it's meant to be a triad of tests to look at someone without diabetes who may have a pathologic cause of hypoglycemia, such as insulinoma. So it's made of 3 components, which is the presence of symptoms, documentation of low glucose, and resolution with carbohydrate load. When we define a low blood glucose, we really define it based on how low the blood sugar is. So sugar less than 4, low. But we initially call this neurogenic or autonomic symptoms. It can present with trembling, palpitations, sweats, anxiety, hunger. Once you get to a blood glucose 2.7 or less, you're not getting enough glucose supply to the brain. And that's when you start to get neuroglycopenic symptoms. So this can be difficulties concentrating, confusion, weakness, drowsiness. And as it progresses further, we worry about the red flags, which is the risk of seizures or loss of consciousness. So obviously we don't want it to progress to that stage. Okay. So how do we correct? This slide and imagery here is from Diabetes Canada guidelines, but the method and the understanding is the same when you're correcting hypoglycemia in general. If a patient is awake and alert, has no IV access, first thing you want to do is treat it. How you're going to do that is with 15 grams of quick-acting carbohydrate. So this can include glucose tabs, such as Dex tabs, which you can buy over the counter at a pharmacy. And the important thing to note is that it's called Dex-4 because you need to take 4 of those large tablets to equate to 15 grams of carbohydrate. Alternates include a tablespoon of honey, a tablespoon of sugar mixed in water, about a juice box, or 6.5 Lifesavers, or 2 packets of Rocket candies. So what you want to do is take your quick acting correction, wait 15 minutes. If your sugar is above 4, you want to eat something that has some protein or healthy fat in it. So usually say like a half a sandwich of peanut butter or cheese. If it's below 4, you do your quick carb for 15 grams again, and then wait 15 minutes, check, and then sort of rinse and repeat the cycle. And then obviously you want to see why this happened and try to avoid this in the future. So this is a slide to talk about a lot of the major causes of hypoglycemia in adults without diabetes, but there are actually further things beyond this list. So one way to divide it is in terms of fasting causes and non-fasting causes. If you're looking at fasting causes, it can be subcategorized into hyperinsulinemic, or not hyperinsulinemic. So when you have hyperinsulinemic causes, it can be things such as insulin overdose or sulfonylurea overdose, autoimmune hypoglycemia, which is where you have an insulin antibody that results in overproduction of insulin, or pancreatic beta cell tumors, or that classic insulinoma that we try to look for. And if someone does have an insulinoma, then you want to also rule out MEN1 or multiple endocrine neoplasia type 1, which is a genetic syndrome. It's rare, but it can be pretty significant, and it can impact the pituitary, the parathyroid, as well as the pancreas. In terms of non-hyperinsulinemic causes, it could be those who have severe hepatic dysfunction, renal dysfunction, because your liver is involved in glycogen storage. So if you impact that, you affect your glucose production or a certain element of it. If your kidney function is impacted, you actually have 15% of your insulin production or sensitivity from the kidney. So it's going to impact that as well. Malnutrition, when you basically deplete all your stores. Hypercortisolism, so adrenal insufficiency, for instance, one way it presents is with low blood glucose. Alcohol abuse, non-pancreatic tumors, so other solid tumors can actually present with hypoglycemia. So if there's no other factors, you do want to do a pan scan to rule out the potential for malignancy. Severe hypothyroidism, and it's also in the calculation score for myxedema coma, and certain medications. These can include beta blockers, quinidine, indomethacin, certain antibiotics as listed here, and then diabetes medications, so repaglinide, sulfonylurea, insulin. From non-fasting causes, it can be post-bariatric surgery. So this is what we call dumping syndrome. So you eat a meal with a high you get a quick processing of it. You do actually end up with a surge of insulin as well, and then a bottoming out of your sugars. Another cause is nistidoblastosis, and this usually presents as postprandial hypoglycemia. And this is similar to pancreatic beta cell tumor, except there's no tumor. It's basically an area of the pancreas that just has overproduction of islet cells, so it just secretes more insulin overall, as well as insulinomas, which can impact both fasting or postprandial. So what are some investigations to do if a patient with hypoglycemia presents in front of you? So you want to do a set of investigations, so blood work, and these should be fasting blood test around 6 to 8 a.m. It would include things such as glucose, A1C, insulin, C-peptide, proinsulin, beta hydroxybutyrate, sulfonylurea level, especially if you're worried about toxicity, TSH, cortisol, ACTH, liver enzymes, if there's liver dysfunction, creatinine for renal impairment, and insulin antibody. Depending on the presentation of the person in front of you, if it's acute, you might want to consider an infectious workup, especially if they present with shock or sepsis, nutritional workup for malnutrition, and a toxicology screen for ethanol or other toxic alcohols. If you're concerned for a lesion, if you think it's specifically pancreas you want to rule out for, say, an insulinoma, you can do a dedicated one to the pancreas or the abdomen. But if there's potential for malignancy, then it would be chest, abdo, pelvis. Now, say you have suspicion for hypoglycemia, but you can't quite find where it is, or you really, really want to prove that it's true hypoglycemia. This is where you start to go into dynamic testing. That's where you might need your friendly endocrinologist. Depending on what we have access to, you may actually need to go to a tertiary center to do some more nuanced testing. So the main way to test for this is to do either a fasting study or a mixed meal study. So a fasting study is basically where you don't give the patient anything apart from water, ice chips, or non-caloric, non-carb liquids, and you fast them anywhere from 12 hours to 72. You check their blood sugars every couple of hours. Once their blood glucose is under 3, every 1 hour. Once it hits under 2.7, or if they're very symptomatic and refuse to continue, then you would send off for blood work. And the blood work you would test would be the glucose, insulin, C-peptide, proinsulin, and an antibody if you haven't done it. A mixed meal study is basically where they usually present with a history of postprandial drops. And for this one, you want to give them a mixed meal. Usually it's the equivalent of actually having them consume 2 quick bottles of Ensure, and then doing the same thing where you're monitoring them hourly and waiting for their sugar to drop, ideally under 2.7, or if very symptomatic and they refuse to continue. Some other nuanced testing, and again, you're really going towards tertiary centers if you're doing this, would be an MIBG nuclear scan to see if they could find the tumor, but it's actually very difficult to get these types of tests done these days. A selective arterial calcium stimulation, which I'll go through shortly, and a PET scan, which will look for those hypermetabolic tumor lesions. Okay, so back to SB. So you decide you want to test this occult cause of hypoglycemia, and you want to do a fasting study on him. So you're doing it every 1 hour checks once his blood or 3, and you actually get him 20 hours into the test to have a venous glucose of 2.2. He's got some symptoms as well, some sweating, slow speech. You give him the glucose, he's instantly better. At the time you test him for those labs that I mentioned, his glucose is confirmed 2.2. His insulin, C-peptide, proinsulin levels are high. His beta hydroxybutyrate is negative. Insulin antibody is negative. His cortisol was negative, and his sulfonylurea screen was negative. So is this hypoglycemia? Okay, so this one is just a nice chart that kind of divides the possible causes for where it can be. So one thing I like to think of is insulin, C-peptide, and proinsulin are all co-components. So think of them as like a Lego block triangle. They go together. They don't separate. If they separate, there's some other issue going on that doesn't quite make sense. So they go high together, they go low together. So in the setting of an insulinoma, all these three are high. There's no beta hydroxybutyrate. Your antibody is negative, no sulfonylureas. If it's sulfonylurea misuse, remember, the way sulfonylurea works is off your GLUT receptor in the pancreas, so it acts similar to trying to release more insulin. So all three components of these are high, and then your sulfonylurea test is high. If it's insulin misuse, so a patient who's taking exogenous or surreptitious insulin, only insulin will be high because it's the exogenous use. But remember that otherwise low in the body. They're not producing more insulin. So everything else across the board for your testing should be negative. If they have an insulin antibody, so an autoimmune culprit, insulin, C-peptide, proinsulin are all high, and your antibody is positive. And if there is another cause, so a non-islet tumor, a solid tumor that I can mention on occasion can cause hypoglycemia, everything is negative, but they're still truly hypoglycemic. Okay, so where do you think he stands on this? I'm going to remove the didactic component and just say he meets the feature for insulinoma. So given the positive fasting study, an MRI pancreas was done, and there was a comment of a possible lesion at the head of the pancreas, but it was really difficult to see if pathologic or not. So the question was, do you just go forward to surgery? It's a Whipple surgery, it's fairly involved, or is there anything that you can do prior to assess? So we decided to pause and look into selective arterial calcium stimulation testing. Again, this has to be referred to a tertiary center. So how do you do selective arterial calcium stimulation? Well, basically you want to go through the cannulate the femoral vein and artery. And then you want to actually have your cannula in a few different areas. You want to have it into your hepatic vein, your gastroduodenal artery, your superior mesenteric artery, and your splenic artery. And why you want it in these vessels is because where it comes back positive, showing increased insulin, tells you where that extra insulin production is. So that way you can have directed surgery for which part of the pancreas is the issue. So is it worse at the head, at the body, or at the tail of the pancreas? So you know where to resect. So in this situation, he had this procedure, cannulated all these areas. They'll test the insulin level at baseline. So even at baseline, if it's a severe enough insulinoma, you might already have a discrepancy in which area is having more insulin production. If not, irrespective, you do give a quick injection of IV calcium gluconate. And what this does is it alters the potassium permeability and it shifts it extracellular, which raises insulin to try to shift it back intracellular. And then when you do this, you look to see which area and which vessel has a sudden rapid rise in insulin. So in this one, the gastroduodenal artery had a significant rise comparative to the other. And this confirms that the lesion is in the head of the pancreas. And this was what came out for Mr. SB. So before we get into it further, we're going to pause the case SB and look at treatment options. So I did talk briefly about an awake and alert person in terms of correcting hypoglycemia. So you've got immediate glucose management that you can do. If you find the underlying culprit, obviously you want to deal with it. So you know where the insulinoma is, remove it. If the patient is taking exogenous insulin or exogenous sulfonylurea, stop them from doing that. Say you can't, or the patient's not amenable to surgery, or you just can't find where it is. If it's hyperinsulinemic hypoglycemia, so where your insulin, your C-peptide, your proinsulin are all high, there are a few medications at your disposal. You can use diazoxide, octreotide, and acarbose. So, sorry, these next couple of slides are from Diabetes Canada, and it talks about treatment of someone with hypoglycemia. So if someone has severe hypoglycemia and they're unconscious or no IV access, then you want to treat milligram of glucagon sub-Q or IM, or give nasal glucagon. Then if they're out in the hospital, call 911 and then have them see their medical team again. If they're severe hypoglycemia and an IV access, treat with 25 to 50 mils of D5W, so an amp of D50, or put it in a mini bag and run it through quickly over 1 to 3 minutes. Retest in 15 minutes, make sure your glucose is above 4. Treat it again if it's still low. If they're conscious, you can treat orally with 15 grams of quick carb. If they're still unconscious, you want to push in another amp of D50. Once they're conscious and their sugar is above 4, you want to feed them a meal. So as I said, a half a sandwich with peanut butter or cheese. Now, if they're severe hypoglycemic in a conscious person, you want to treat with 15 grams or quick-acting carbohydrates, as I mentioned with the infographic earlier. Retest in 15 minutes, above 5, feed. Below 5, another 15 grams, wait 15 minutes, treat again. So what's the difference between intramuscular versus intranasal glucagon? So before I get into this study, I'm just actually going to show you it quickly because I managed to have to find a box here in the diabetes clinic. So before intranasal glucagon came, we only had this box and this kit available. And so for people who had diabetes who were on insulin, this was all we were able to use. But as you can see here, it's incredibly cumbersome. So the way you had to do it was you had to take the syringe with the saline in it, inject it into the powder, shake and reconstitute the powder, pull it up into the syringe, and then do a sub-Q or an IM injection. Now, having someone do that, like a loved one, while a patient is seeping into unconsciousness and everyone is panicking, is not good because you're more likely to mix it up, mess it up, panic, not sure what to do. So recently, there was the creation of nasal glucagon. So the brand name for it is called Baqsimi. And basically, this is what the container looks like. But if you pick it up from the pharmacy, it's actually going to be a yellow container. Now, it's covered on label for those who have diabetes on insulin. So obviously, for the setting of my talk, it would be purely off-label use to use something like this. But I'm just explaining, just to tell you physically what other safety measures we have for correction of hypoglycemia in a patient who is losing consciousness. So it'll have a shrink wrap on it. You remove the shrink wrap, basically open it up, and you open it up here, and it's got one nostril. It's one per use. Put it into the nose, push it. You get a puff of intranasal glucagon and should help wake someone up. And then obviously you want to get them food, you want to get them medical assistance, etc. So if you have patients who are on insulin, especially if they've got coverage, government or otherwise, then this is a great thing to prescribe just as a safety measure. If they have government coverage, the LU code is 625. If they don't have coverage, then believe it or not, the kit is actually much cheaper. The nasal glucagon is around $230 for one bottle. So just a takeaway point is something to consider. So this is just one of the studies that was done to look at intranasal versus intramuscular glucagon. So they looked at 75 adults who had type 1 diabetes. Mean age was 33. And what they did was they purposefully induced insulin by giving them IV insulin. And then they either gave them intramuscular, which is 1 milligram of the glucagon, or intranasal, which is 3 millimeter. And the definition of success was a blood glucose above 4. So 70 milligram per deciliter is equivalent to 4 millimole per liter, or they at least had a rise of 1.1 millimole per liter, or here 20 milligram per deciliter from the glucose nadir within 30 minutes after receiving glucagon. So they found success with using the intranasal was around 98.7% versus 100% for the intramuscular. And mean time to success was about 16 minutes for intranasal versus 13 minutes for intramuscular. So I know it looks like the intramuscular comes out ahead, but remember, when you're in a research study, there's probably more education. It's a little bit more of an ideal environment as opposed to real world. So I'd still say, even though you know it would be 100% comparatively, so much easier to use, and much easier to use when you're panicking and you're not having to finick and try to reconstitute and inject it in. Okay, so what are some of these other treatment options? So I'm starting first with octreotide because this is the one that tends to be most effective in correcting hyperinsulinemic hypoglycemia. So it's basically a synthetic octapeptide analog of somatostatin, which can effectively suppress insulin secretion. You dose it as 1 mic per kg, not to exceed 50 mics per day, and you want to give it sub-Q or IV, so you can get the injections for octreotide, and you want to give it 2 to 3 times a day. Now, you do want to be mindful because it's not without adverse effects. It can result in, because as you increase somatostatin, these are some of the effects that you can get. So you get risk of cholecystitis, cholelithiasis, pancreatitis, hypo or hyperglycemia. So if you have too high of an octreotide dose, it can actually cause your blood sugars to go quite high, hypothyroidism, and QT prolongation. Your other treatment option is diazoxide. So the way diazoxide works is by suppressing insulin secretion by blocking the sulfonylurea receptor 1 subunit of the KATP channel of the pancreatic beta cell. So this increases the permeability of the potassium ions, results in hyperpolarization. So you suppress the need for insulin to work as much to try to push potassium intracellularly. The way you dose it is about 3 to 8 milligram per kg divided BID to TID as a starting dose. Again, there's adverse effects with this medication, so just be mindful. It can cause fluid retention. It's probably the major side effect. GI upset, hypertrichosis, so unwanted hair growth, neutropenia, pulmonary, and thrombocytopenia. And your last option is acarbose. So acarbose is a pill that basically works to prevent the breakdown of sucrose and delays glucose absorption. Acarbose is also used quite often in individuals who've had gastric bypass, who have that dumping syndrome. So they take acarbose to just reduce how much glucose is absorbed in the body to release that, to prevent the release of that excess insulin secretion. The way you dose this is about 50 to 100 milligrams tablet TID with meals. Now, again, this has adverse effects, so you want to be mindful. The main one for this is actually gas, bloating, diarrhea, and rash. So going back to SB, he had the selective arterial calcium stimulation test, positive, high in the area of the gastroduodenal artery. So he had surgery done to remove the lesion. He had a Whipple's procedure. Tumor was seen in the head of the pancreas. Pathology showed an insulinoma, 0.8 centimeters, grade 1, Ki67 was 3%. He also had testing of MEN1, as I mentioned, because he did have a finding of an insulinoma, and the results were negative, which is great. He had resolution of his symptoms. So just to summarize, in unusual cases or ones that don't make sense, don't just assume pseudohypoglycemia. Like, you want to make sure to rule out that it's a real low sugar versus a fake low sugar, and repeat careful testing is needed. CGM can be helpful in this situation, but remember, it can sometimes be inaccurate because it has its own risk of pseudohypoglycemia. So make sure you've problem solved that before you take it at its word. And we actually see in individuals who are wearing CGM for management of diabetes that sometimes they have a lot of dips and lows. And we always ask them to double check with a finger poke to actually confirm accuracy of it as well. So remember to double check, assess the reasons why. Refer onwards if you need assistance. Make sure if someone is presenting without diabetes with hypoglycemia, you evaluate for the Whipple's triad. That's your first series of symptoms to ask versus none. Once you want to get further assistance, you want to get more specialized management, more specialized dynamic testing or imagery, you may need to refer on to a tertiary center or an academic center just to help further do those testings and evaluations for that patient. So I hope that you were able to identify the symptoms and risk factors for hypoglycemia in those without diabetes via these case discussions. You now have some strategies for quick and long-term management and that you are more familiar with managing this. So with that, I'm happy to take any questions. Oh, and I have a comic at the end. If anyone hasn't seen the Awkward Yeti, they have a lot of fun comics. So if you have any questions, you can feel free to unmute or put it in the chat box. Thank you. If there's no questions, then you guys are free to leave, and hope you have a great day. Okay, I'm going to shut it down then. Thanks. Take care, guys.